Hi, I'm Katie Crane, and this is the Pilates Lounge. Hi there, everyone. My name's Katie Crane. I'm the Pilates professional. Welcome to another episode of the Pilates Lounge. Now, today's episode I know is going to be absolutely fascinating for any movement professional and even any movement lover. We're going to be delving into EDS and hypermobility. Now, my guest today, Jeannie Di Bon, is an expert on EDS or Ehlers-Danlos Syndrome and hypermobility. Jeannie is from the UK and she is an international advocate, and she's an internationally recognized movement therapist who specializes in working with people with hypermobility, Ehlers-Danlos Syndrome and chronic pain. She regularly presents for the EDS Society at their international conferences, and her own journey is personally one of a chronic pain sufferer. Jeannie herself lives with hypermobile, bendy, and an unstable body, and she experienced 3 episodes of pneumonia that left her with a lifelong lung condition called bronchiectasis. She now has the diagnosis of hypermobile EDS and mast cell activation syndrome, as well as POTS and chronic fatigue. So I know that a lot of us in the movement world can really resonate with many of those names. And I'm hoping that by bringing Jeannie onto the show today, we can maybe understand better how we can work with people with hypermobility or EDS, but also how we may be able to empower these people with movement and specifically with Pilates. Jeannie is an international voice for EDS sufferers. She's a member of the London Hypermobility Unit Network of Excellence. She is an EDS Community Champion Award winner, and she has been awarded the prestigious Community Champion Award for services to the hypermobile community by Ehlers-Danlos in the UK. Jeannie's written several books about these conditions, including Hypermobility Without Tears and Pilates Without Tears. I will definitely reference these books in our show notes if you're interested in looking into any of Jeannie's works. And of course, she has some online programs for us as movement educators to understand better, but also somewhere that we can send our clients to if they're looking for more support. I'm going to hand over the microphone to you right now, Jeannie. I could keep talking about you without you ever even having to say anything, but I don't want to. So welcome to the show, Jeannie. Thanks so much for joining me all the way from the UK. I would love for you to introduce yourself, and we're just going to keep conversing really naturally once you've introduced yourself, and tell us a little bit about your own story first so that you can paint a picture of where you are in your life and how you came to be such a well-known advocate for EDS and hypermobility.
Thank you so much, Katie. And that was a wonderful introduction. Thank you. And thank you for inviting me. It's an honor to be here. And yes, as a Pilates, my foundation is Pilates. And actually, it was Pilates that really helped me out of a hole, I guess I was in many, many years ago. So yeah, I'm really happy to talk about that journey and share how powerful, Pilates can be for people with hypermobility and EDS. So I guess my journey started probably around the age of 13. I started to get pain, shoulder pain. I started to get what was called IBS, any kind of digestive issues. Doctors tend to just tell you you've got IBS. And that was at the age of 13. And that's kind of lived with me my whole life. I went through a lot of different issues as I sort of went into teenage years. Problems with my jaw would lock overnight and it would get stuck, and I started having a lot of chest problems. So yes, I've had 3 episodes of pneumonia as an adult, but as a child, I always had chest infections. I was always, sickly through the winter months. So lots of different issues going on, Migraines, they started when I was about 18, 19, and they were daily, really debilitating. But you kind of live with these things because you just start to think this is normal, right? You have all these different issues. You assume that everyone has all these issues. And I just kind of got on with my life and started work. I had a different job back then. I worked in human resources. So I had an office job, a corporate job in the city in London. And then I had children quite close together. And that's when my problems really started. And things went downhill from there. So that's when I started getting my pneumonias and chronic fatigue. And again, I didn't know it was chronic fatigue. It was just, I thought all new mums had this sort of devastating tiredness that, couldn't do anything. And you have two young children running around. It was pretty tough. But eventually, and you know what it's like. If anyone here is listening has got children, you know what it's like as a new mum. You don't really prioritize yourself. You're looking after the children all the time. And because of that, it enabled my left shoulder to start to have a chronic issue. I kind of ignored it. And eventually I kind of lost all the sensation down my left arm. So I couldn't push the buggy anymore. And, I thought, right, I really have to go and see someone. So I went eventually to a physio. And a physio, this guy said to me, you have no stability. I didn't know what he was talking about back then. And that's the thing. I had zero body awareness. I didn't really know anything about anything. And he was like, you have no stability. You're hanging off your joints. You've got terrible posture. And I was like, okay, well, what should I do? So he said, you need to do something like Pilates. And I was like, oh, this was back in 2007. And I was like, well, I've heard of it. I've never done it. Anyway, I started Pilates and I fell in love with it pretty quickly. And, within about 6 months, I was like, this is what I want to do. This is what I want to do for, I don't want to go back to the city. This is what I want to do. And that's how my sort of Pilates journey began. I started training as a mat work teacher pretty quickly, and it kind of went on from there. Of course, all through this time, I continued to have problems, not pain problems. So through movement therapy, through Pilates, I managed to get my pain under control, which was fabulous. But I continued to have other issues, other systemic issues like my gut and my lungs and the headaches. All of that continued. But I still didn't know I had hypermobility even. No one had even pointed that out. And I certainly didn't know I had EDS. So it wasn't until, my boys were sort of young. They were, it was probably around sort of 2011. I went to a different physio who was the first person ever who said to me, you're hypermobile. Do you also have digestive issues? And I'm thinking, well, what's that got to do with being hypermobile? And I was like, well, yeah, I've always had digestive issues. And so she didn't really say anything else, but she was working a lot with hypermobile and EDS patients. So I was teaching Pilates by now. So she started sending me EDS patients. So around 2011, I had my first exposure to EDS patients, and I have done ever since. So I've been working with the community since about 2011. So 2011, I started working with EDS patients, and the more I work with them, I'm thinking, God, this is familiar. I have these issues. And, so I started to learn an awful lot about the condition without knowing I had it. But I kind of thought I could have it because I'm so similar to these people that I'm seeing. So anyway, I started to get more and more EDS patients. And instead of being scared of it, because a lot of people are scared of working with EDS patients because, some people are very, very complex and they do have multi-systemic issues. But I was kind of curious. I thought, gosh, how fascinating that there's a condition that impacts every single system in our body. How fascinating is that? And what can we do to help these people? So I continued working with them, more and more and more clients. In fact, now I don't see anyone else apart from EDS clients. So it kind of grew. And now I specialize only in EDS clients. But it wasn't until again, it's quite a long journey, which sadly isn't unusual for people with EDS. It wasn't until 2017, when I was 48 years old, that I actually got my own EDS diagnosis. And that was because, again, I can talk more in detail about, the triggers and things for these conditions. But I became very ill. I had a very stressful time in my life in 2017. My mother died very suddenly of cancer. And the stress of that, together with the stress of going into menopause or perimenopause at the same time, triggered what I now know is mast cell activation disorder. And I had that diagnosed at the same time. When they saw I had mast cell activation, they then did a clinical diagnosis of hypermobile EDS. So that was back in 2017. So I've only had my diagnosis. So where did...
So 2017, so you said 2017 when you got your diagnosis from...
Yeah. So I got my diagnosis in 2017 along with the mast cell activation syndrome diagnosis. And we can talk more about what that is. Because it's a relatively new thing that's only just coming to light. And alongside that, I also have POTS, which is postural orthostatic tachycardia syndrome, and chronic fatigue syndrome. So unfortunately, a lot of people who have EDS often have what we call the terrible trifecta, where they do have these other comorbidity conditions like MCAS, mast cells, and POTS. And obviously then you're dealing with a lot of different issues, as well as the sort of the muscular-skeletal issues presented by the hypermobility. So yeah, it can be, it's a sliding scale. You might have people who are very mildly affected and they function pretty well and they can go to work and they live a pretty normal life. Or you can have people who are at the other end of the scale who are extremely disabled by it, housebound. Some people, unfortunately, fed by tubes, lots of operations, things like that. So it is a scale. So, but I do see from mild to very complex patients in my clinic. So, yeah, that's kind of my story, how I got to where I am. I'd say it kind of grew organically from, working with one or two EDS patients, and then it just grew and grew and grew. And so now I have patients all over the world. With the pandemic, obviously, I started getting contacted from people all over the world, Australia as well. So I've got some lovely Australian clients. So with Zoom, obviously, I can reach so many more people as opposed to just having my local sort of studio here. So it's wonderful. And I have people coming to see me from all over the world as well, which is amazing. So that's how I got to where I am today.
That's awesome. What a fascinating story. Now, I know that a lot of our listeners are going to be thinking, wow, that's an amazing story, but what exactly is Jeannie talking about? What is EDS? Where does the name Ehlers-Danlos Syndrome come from? Exactly what is it, and how does it get diagnosed, and even what does a sliding scale mean?
Yes, and great questions. So Ehlers-Danlos, let's start with that one. Ehlers-Danlos were two sort of, I don't want to say scientists, two doctors, Dr. Ehlers and Dr. Danlos, who many, many years ago, so we're talking early sort of 1900s, started to notice in their patients sort of skin issues. They had what they call stretchy skin. And you might have seen photographs of people who can really stretch their skin. Yeah. So one of the sort of symptoms of this condition is that there's changes in the skin. And why is there changes in the skin texture and the quality of the skin? Is because of the connective tissue. So what we know is that EDS, Ehlers-Danlos syndrome, is a connective tissue disorder that impacts the makeup of the collagen. So instead of the collagen being very densely bound together and strong, and if you've ever seen sort of pictures of sort of collagen, it's very closely knitted together. It's very, very strong protein. But in EDS, in a connective tissue disorder, of course, there are other connective tissue disorders. EDS is one type of connective tissue disorder. But in EDS, you'll see that the collagen, instead of being tightly woven together, has sort of gaps in it. Yeah, so it's not as strong as it should be. It's not as elastic as it should be. So that's one of the features of it, is that you can normally tell when you have somebody with EDS when you touch them. If you're a teacher who does sort of hands-on corrections and tactile cueing, their skin is very, very soft. We call it sort of doughy. So it's almost like a baby skin, you know? If you've ever touched babies, you know, they have that very soft, sort of squidgy skin. That's kind of what EDS skin feels like. It's really quite different when you touch it. So that's one thing that, you know, we know is definitely on the criteria is the changes in the skin. But as I said, it's a connective tissue disorder. And because it's to do with the collagen in the tissue, and the collagen is obviously everywhere, it can impact any system in the body. So, you know, as Pilates teachers and therapists, we're obviously looking predominantly at movement. So we're looking at the muscular-skeletal system, which could obviously involve joint laxity. So hypermobility is a feature of EDS, or the hypermobile type of EDS. I should mention there are 13 different types of EDS. Hypermobile EDS is the most common. So that's predominantly what you would probably see coming to your classes or to your lessons are the hypermobile EDS people. The others, some of them are extremely rare. I have not seen to be honest, I've seen some. There's another type called classical EDS. I have some classical EDS patients, and I have never ever treated any of the other types of EDS because they are extremely rare. We have vascular EDS, which unfortunately can be a fatal condition because it can lead to aneurysms, you know, blood vessels suddenly in sort of bleeding, etc., internal bleeding, things like that. You know, that's quite a serious condition, unfortunately. But as I say, mainly you're going to be dealing with the hypermobile type of EDS. So yes, as I was saying, it affects all the systems in the body because it's connective tissue, which is everywhere in the body, which is why, for example, if we take me as a case, I have problems with my lungs. So I've had multiple pneumonias. I have a mitral valve prolapse in my heart, which is extremely common in hypermobile EDS, and people should have regular checks for their hearts. So I have sort of a floppy valve in my heart. I have problems with my gut, so my digestive system. I have problems with my bladder, so my urinary system, and I can talk about that because that's what led to my diagnosis, actually, was these problems I had with my bladder. So I have pretty much, and then of course the POTS, that's an autonomic system. So that's again part of it. So I have problems with my autonomic system. So you can see how it affects multiple systems. But if you look at me and I'm on Instagram, I'm on, YouTube, etc., I look normal. It's not like you say, oh, she looks really sick. She doesn't look, there's something wrong with her. She looks ill. Most days I don't look ill. I look pretty normal. And that's a problem that we have with EDS, of course, is that we have, a lot of misconceptions. And, people say, oh, there can't be anything wrong with you. You don't look sick. You don't have to look sick to have EDS. You don't have to be disabled to have EDS. People get a lot of backlash sometimes. Some days people might need to use a wheelchair or might need to use a walking aid, and the next day they might not. It depends on how their symptoms are going because it's a very variable condition. So, there are a lot of myths and misconceptions out there about EDS, sadly, which I try through my work. I did a whole series on YouTube about the myths surrounding EDS. So if you're interested in learning more about, the myths that are out there, the things that just aren't true and are actually quite harmful to people with EDS, then please do take a look at those on my YouTube channel. So yeah, EDS, Ehlers-Danlos, connective tissue disorder, affects multiple systems in the body. And for us as movement professionals, we're looking at the muscular-skeletal system. So how can it present itself in the muscular-skeletal system? So joint laxity. So you're going to have people possibly who are very bendy in some of their joints, maybe not all of their joints. So some people are very bendy in some joints and very stiff in other joints. So just because someone's hypermobile doesn't mean they're going to be bendy all over. I have extremely, extremely tight hips. I can't do the splits. So that's probably another myth, just because you're hypermobile doesn't mean you can do the splits. Can't do anything like that. But most of my other joints are mobile, hypermobile. So you're going to have, things like, does that person have control of their body? Have they got good proprioception? And we do know through research that people with hypermobility, not just EDS now, I'm talking hypermobility as well, they lack proprioception. So they're unaware of where their limbs are in space, how to control their limbs in space. So, of course, through Pilates, what a brilliant way to teach proprioception. It's a fantastic way of teaching that. We've got so many tools either on the mat or on the equipment, the reformer, etc. Loads and loads of opportunities to help people with that. So we're dealing with things like that. You might be dealing with people who, because of the laxity, have things like subluxations and dislocations, particularly around the shoulder joint, which is obviously the most mobile joint in the body. So how can we help manage people's subluxations and dislocations? So we're going to need to appropriately do strength work, stability work, resistance work, again, the machines, reformer, trapeze, etc., or bands and balls and magic circles, all of that, fantastic for helping. And of course, pain. So we do know that pain is the number one symptom that presents itself in EDS. So chronic pain, I had chronic pain. Again, my pain started when I was 13, but through movement therapy and the Pilates repertoire, I was able to get myself out of pain. And as I said, I wasn't a dancer, I wasn't a gymnast, I was just an ordinary person. So I had zero body awareness. No one had taught me anything about how to move my body. So, I was probably hyperextending my knees. And as the physio told me, I had terrible posture. So I was kind of in that hanging, those hanging postures that we also often see, locked knees, forward pelvis, forward head. I was one of those people. So helping people with their body awareness, their alignment, all of the things are so, so important. And that can all be done through Pilates. So, amazing. It's an amazing thing. And it's, generally it's slow, isn't it? You can make it slow, which is what we need to do. Safe, slow, controlled, and of course, breath. Huge part of it. Teaching people how to breathe properly, because a lot of people have got breathing pattern dysfunction as well for a number of reasons. So many reasons why Pilates is fantastic for EDS and hypermobility.
Oh my gosh, I've got so many questions. Where do I start? Okay, so assuming that, that a lot of what you experience, if you do have EDS, say, whether it's heart condition, gut condition, hypermobility in the joints, is because of the composure of your connective tissue. So it's almost like the connective tissue collapses in on itself somewhat, or the structure isn't strong enough and doesn't have the same rebound capabilities, is it? Okay.
Exactly. It has less elasticity. Yeah. So just because someone's hypermobile, I don't think that means they're elastic. We want an elastic body, a fascial, if we talk about the fascia, obviously that's connective tissue as well. We want, definitely fascial friendly movements to help build elasticity. It's not stretching. We don't want to stretch just because people are I always say, just because you can doesn't mean you should. People often make the mistake with hypermobile people, and yoga often gets a bad press because of this. And I think that's unfair because yoga it has a lot to offer as well. But, they see someone who's bendy, it's like, oh, you can do more, you can go further, keep going, stretch. We don't want to do that with hypermobile clients. Yeah, we don't want to stretch them more. We want to build elasticity. Yeah. So, and of course, if you keep stretching, we're very good at hanging off our joints. So we can cheat and we'll just hang. And if you think you're stretching something that's tight, you're probably not. You're probably just stretching the joint. So be very careful with stretching hypermobile people. Exactly. Perfect. Yes. So yeah, that's another of the misconceptions is you might have clients who have asymptomatic hypermobility. They're just hypermobile. If you think about dancers, gymnasts, a lot of athletes, being hypermobile is actually a real advantage because they can do amazing things, right? Ballet dancers, amazing. Doesn't mean they've got a connective tissue disorder. They're just hypermobile. The problem we have is when that hypermobility becomes symptomatic, then so you can have symptomatic hypermobility, you start to get pain, you start to get the subluxations, etc. Then then we start looking at, well, is it more than that? Is it a disorder? And this is what I find so fascinating. This is the really interesting thing about this condition. It can suddenly, you can have people who have had, let's say, a normal life, pain-free, doing their thing, going to work, going to university, whatever, playing sports, living a normal life. Something happens to them. Okay, now that can be any number of things. They could have COVID is a good example, some sort of viral infection or glandular fever or Lyme disease. Okay, things like that, these highly inflammatory viruses, Epstein-Barr, all of that kind of thing. They could have a trauma like a car accident. The number of clients I have who have fallen off horses and banged their heads is quite remarkable. So they could have a car accident. They could become pregnant, or they could go into the menopause, or they could start adolescence. Any of those things, because it's tipping the nervous system, that for that person, whatever that is, and for you and me, might say, well, that's not stressful. But for their nervous system, they've decided that's stressful. That is enough in some cases to trigger symptomatic hypermobility that then leads to an EDS diagnosis. And these are people who can go their whole life with nothing. Yeah. So some people I've met only started having symptoms in their menopause. For me, it was in adolescence. Okay. So my symptoms started in adolescence. So why pregnancy, menopause, adolescence? Why is this important? Because we don't know much. And that's the problem with EDS. There's not a lot of research. We're trying to catch up on the research because not much was done in terms of research. We don't know an awful lot, but we do now know that the female hormones are a huge driver in the symptoms of EDS. So when a lot of times I see a lot of young women who have started university, big life change, leaving home, stress of university, they were perfectly healthy, and then all of a sudden they're wiped out, they have to leave university, their kind of world implodes. And that's because of the hormonal changes that they've gone through and the stress that they've gone through. Any kind of stressful event, a bit like me with my mother when she passed away in 2017, the stress of that and, the shock and the onset of perimenopause was enough to trigger. I got so ill at that point. I was probably the sickest I've ever been, apart from the pneumonias. It was enough to trigger the mast cell activation. And that's what led to my EDS diagnosis. And that diagnosis, even getting that diagnosis, took a good 18 months because doctors would not listen to me. My own doctors would not listen to me. I was dismissed constantly as these things just happen to women of your age. It's nothing, very dismissive comments. And eventually I found somebody who did understand and who was EDS aware. And that's how I got my diagnosis.
But hypermobility is different to EDS, even though a lot of people with EDS have hypermobility, correct?
But yeah, this is what's fascinating even more, I think, about this condition is that it can suddenly come out of nowhere and totally derail somebody. And then we have to pick up the pieces, so you might have people coming to your studio, to your clinic, who have got a lot of emotional upset and anger because they don't understand, where's this thing come from? I had a normal life until 2 years ago, and now I can barely walk up the stairs. What is going on? So frustration, upset, EDS patients, it's not just a physical thing, it's a huge emotional thing as well. And I think that often gets underestimated when we're dealing with our EDS, symptomatic hypermobile EDS patients. This is why when I developed sort of my modified Pilates program called the Integral Movement Method, the IMM, the first two steps in the IMM are breath and relaxation, because so many people were coming to see me and they were, I don't know if you've ever seen, I'm sure we all have seen people who present themselves. They've got a very, very rigid thorax, like their ribs don't move when they breathe. They can't breathe properly. They can't let go. They're carrying so much habitual tension in their tissues that they're rigid, despite being hypermobile. This part of their body is totally fixed and locked down. And I believe that a lot of that, yes, it's a functional thing, it's a muscular thing, but that is driven from a lot of this emotional stress and this history of being dismissed, not getting diagnosed, living with a condition without the appropriate support. All of these things, they go into somebody, that they're a form of trauma in themselves, and that shows up in your body. So I had to have breath and relaxation as part of treating the EDS community, because there was no point thinking, right, and this is the mistake that's often made, like in physiotherapy and in PT, is that people see someone who's hypermobile, oh, you've got lax joints. What you need to do is stabilize and strengthen. So they straight away give them loaded exercises with weights or, bands or whatever. But the person is still rigid and fixed and isn't even breathing properly. And they've got so much tension in their body, and probably not in the correct alignment either, because obviously the muscles are tense and pulling us out of alignment. And then they try and strengthen, and you're putting tension on top of more tension. And then they get more pain. And then the patient doesn't like physio because it makes them worse. And so you get this awful spiral where nobody wants to do their exercises because it's painful. But if we could just step back and say, let's just spend some time breathing. Let's lie on the mat, lie on the floor, wherever, and let's just settle and breathe. And you'll often get some emotional release, of course, but people will thank you for it. Sometimes we think, oh, we've got to teach a load of exercises, got to go through all of these. Actually, I would say less is more when you're working with EDS patients, because sometimes they can only do one rep of an exercise, or they can only do a couple of exercises in a session. Sometimes they just want to talk. And that's all great. That's good too. I think as teachers, sometimes we feel, I'm a teacher, so, I know all these exercises, I'm going to fit as many as I can into this session. And actually, we need to do much less with an EDS patient, because you're dealing with so much more than just the muscles and, the muscular system. There's so much more.
And I feel like quite often we've had a few EDS clients over the years, and I feel like they come in so wound up, potentially, like you say, from living with the stress of not having something that is so visibly obvious to everybody else, and going to multiple appointments, trying to figure out their own puzzle and not feeling like they've got the support. But is it also, because of that hypermobility, or because of that connective tissue not having the rebound, that then the muscles tighten up so much to try and give support? Is that part of it?
Absolutely. Yeah, spot on. Yeah. And that's the other thing, right? You're like, gosh, how can you be hypermobile, but you're also so tight? But yeah, so what happens is you've got this laxity in the joint. So the muscles around the joint go, right, we better work super hard and try and stabilize this joint. But often it's the wrong muscles that are trying to stabilize the joint. So that's part of the problem. The global muscles, the big guys, try and stabilize the joint. That's not their job. The deep stabilizing muscles don't do anything. So they're not working. So then you get these global muscles that are doing the wrong job. And yes, they get fatigued, that because they're not designed to stabilize. And so they get tighter, and then they get sore. When my left shoulder was, that was sort of my first real troublesome area. My left pec was so tight. My left shoulder used to sit in this forward position because the left pec was so, so tight. I couldn't, that exercise, well, I call it windows, where you bend your arms and rotate the arms back, creating sort of a window shape. I could not get this left arm anywhere near the floor because the pec was so tight. And no amount of, and of course, I was always told, stretch your pec, You've got to stretch all the things against the door frame and all of this. None of that worked. Did that for years and years. Did not work because those tight muscles will never let go until somebody wakes up the stabilizing muscles. So when I started to train my posterior chain, I'm like, okay, let's get the back of the shoulder working. Guess what? The pecs slowly started to let go because they understood that somebody else was now doing their job. So it's all about balance. Yeah, you've got to have the balance in the tissues. But yeah, you're going to see people who are super tight, even though they're hypermobile. And that's a protective thing. Yeah, everyone's tightening up to protect the joint. So a way around that, of course, again, relaxation, awareness, letting people, have some time to settle into the mat is really helpful. And then, going super slow, I would say really go low, go slow, because if they go slow in their movements, like super slow, then the deep stabilizing muscles have a much better chance of having a look in and doing some of their work. Whereas if we just let them go fast because of lack of proprioception and control, then we're never going to change their movement pattern because they'll just continually recruit the wrong muscles to move. So going slow will help an awful lot in changing that pattern.
Mm-hmm. And if you're working with somebody with EDS or suspected EDS, do you have a preference between mat work or machine? Like because of that lack of proprioception, do you find that the machines are going to give somebody feedback or something like a chi ball is going to give feedback? And if so, how does joint placement play a role in helping somebody load up?
Yes, it's a really good question. So I do both, and obviously a lot of people I teach, I don't just educate Pilates teachers, I do educate yoga teachers, physiotherapists, etc., who don't have access to the equipment. So I do a lot of strategies on the mat and help with that. Yeah, I use the balls, the bands, the magic circles, etc., things like that, anything to give extra feedback. But for those people who have access to the equipment is just phenomenal for hypermobile and EDS patients, if obviously done appropriately, of course. So one of my favorite exercises, go right back to basics, is, reformer footwork. Just amazing for people who have never felt connected to their feet, in a functional way, helping them feel the foot to pelvis relationship, in terms of that connection, so important. People love it. And when they come off and we stand and we're like, how do you feel? They're like, I've never felt this before. I just feel amazing. And things like, reformer footwork, we were talking about, the hyperextension of the knees, how amazing. You can safely teach someone how not to hyperextend their knees and be in a sort of an upright position. If we turned the reformer upside down, they'd be standing. What a great, safe way of teaching things like joint placement. We don't have to hyperextend our knees. You can actually get your muscles to hold you up rather than locking out the joints. So yeah, I mix it up a bit. When I'm in the clinic, obviously, yeah, I'm using the equipment because it does help get that understanding. Oh, this is where my shoulder blade is supposed to sit. Yeah, supine arms on the trapeze table, another one of my favorite exercises, because it's so safe and it gives them that sense of weightiness in the back of the body. Where are my shoulders? I can definitely relate to that. I had no idea where my shoulders were supposed to sit. That was one of the transformative, oh, I can't talk. transformational exercises for me, I spent a lot of time doing very basic exercises like supine arms on the trapeze table. So yeah, super helpful for the understanding of where the joint is in space and not to hyperextend those joints, which is so common. We all love to hyperextend our joints because we're searching for that stability. If I lock my knees, subconsciously, I think I feel stable, but actually I'm really not very stable at all. But if that's how you've grown up and no one's ever shown you anything different, that's your movement pattern. So as therapists, it's our job to help them understand the role of the muscles in supporting the joint and not the other way round.
And speaking of hypermobility in general, because EDS is complex and it's not something that we're all going to be working with, or maybe it's something that, that we're going to work towards working with. When we're working, say, in a group class environment, so EDS, like in our studio, and and I'm assuming you're the same, we see those people one-on-one, and maybe once they've got a handle on everything and they can really feel into their body better and know where they are in space, then we might put them in a very small group of individualized sessions. But say if I'm doing a group class with people, it's a generally choreographed class where everyone's doing the same thing at the same time. And I can see that there's people in the class who are hanging in their joints, they're hypermobile in their elbows in 4-point kneeling, or I can see it there hanging in their hips and their knees. Is it dangerous for somebody who doesn't feel pain? Or is it important for us to be teaching better joint placement for those people for long-term joint health?
Yeah, super important. Yeah, I mean, they may not feel pain. That's the weird thing, right? Because they're just used to it. Or they may not feel pain today. It may present itself in a few years down the line. So yeah, if that, in a situation like that where you've got a group, I would be cueing, rather than sort of, isolating that one or two people, but cueing that softening of the knees, whatever exercise we're doing for everybody. Because I think everyone can benefit from it anyway. But yeah, really super important, because of course, the more they do that in everyday life, and they will, if they're doing it in Pilates, they're going to be doing it in their everyday life. When they're standing in a queue, when they're picking up a shopping bag, they're going to be locking those elbows. We can help them. Less wear and tear on the joints. Yeah. Less repetitive strain injuries, because once you lock that joint, the muscles aren't working anyway. Yeah. So we've got to help them get the sensation. I talk a lot about sensation because a lot of people are so disconnected to their body that like me, I had zero awareness when that physio told me you're hanging off your joints and you have terrible posture. I have had no idea what he was talking about, because that's how I was. I was like, I literally did not compute what he was saying. And there'll be so many people like that. They just like, oh, I didn't even know. That's what they say to me. I had no idea that was wrong, or I didn't even know I was doing it. So if we can gently point that out, even in a class environment, with some cues for everybody, and maybe, at the end of the class, you could take them aside and say, hey, I noticed you were doing this. How about trying it this way? They'll really, really love that. And probably no one's ever picked that up before. So I think it's really helpful, be on the lookout for your hypermobile clients in your class, because honestly, people won't have told them. They just won't have told them. So yeah, we can really, really help change someone's whole relationship with their body, which is amazing.
Yeah, in our sessions, we call it the tremor of truth. Once you get out of hanging in your joints and you're in your muscles, you can feel those muscles working so much better and feel stronger and more grounded and supported.
Yeah, I love that. The tremor of truth. Yeah, that's so true, isn't it? You do, because things start to shake, because those guys have never worked before, right? So it's like, whoa, what's going on? I don't know how to deal with this. But I say to people, don't worry. This is a good sign. Don't be put off by the shake, embrace the shake. It's part of the journey. So yeah, but yeah, I do love that. I'm going to use that one.
And Jeannie, so you've spoken a bit about, that the skin can be a factor, and it's, it's It's the most beautiful looking skin. I mean, it's like opposite to my, I'm always like in the sun and got a handbag, leather handbag for skin. But, so the people with EDS or hypermobility, they have this beautiful, milky, soft skin, this makeup of their tissue. Are there other features? Are there certain facial features, or, do they tend to have like a type of kind of hair or anything like that might represent EDS?
No, not your hypermobile ones. I mean, there's some of the other types of EDS. Yeah, you've got, there are certain things, like we have one called periodontal EDS that's going to change, the presentation of the teeth, etc. But no, there isn't really a look. Everyone looks very different shapes and sizes. Something like Marfan syndrome, again, which is another connective tissue disorder, that's where you're going to see a very specific facial and bodily presentation. So people tend to have very long faces, very long limbs. Again, I've only ever worked with one person with Marfan syndrome, but it's a very similar connective tissue disorder, but they do have a very specific look. But no, with our EDS patients, not really, unless you're getting into the rarer types. No. Some people have, the translucent skin. Yeah, so some areas are quite translucent. The other thing, obviously, with the skin, and you might notice in your clients, is because it's delicate, they bruise very quickly and easily. So if they bang into something in a bit of equipment or something, or sometimes you wake up with just random bruises. You have no idea where they came from. So bruising, if you see a lot of bruising, that could be an indicator. And the other thing is scarring, because the tissue tends to heal slightly differently. It doesn't knit together because of the collagen defects. When you have a cut or a scar, it might not knit together nicely. So you might see people with these sort of raised scars on their hands or wherever, their legs, wherever. And that's because of the healing. So we have delayed wound healing, and it doesn't always heal as smoothly and as nicely as a sort of a non-EDS person. So those are some of the sort of characteristics that you can see. The other thing, I mean, I don't diagnose, obviously, because I'm, as a Pilates instructor, we don't diagnose, but I have been able to direct people to get a diagnosis by noticing something on the feet, which is quite interesting. And they're called piezogenic papules. And you'll only see this in a weight-bearing situation. So I remember seeing it once when a client was doing elephant on the reformer. So when they stand, you get these little lumpy little papules around the heel, around the fatty pad of the heel. And when they sit down, they disappear. And so these little fat pads are literally fat that's been pushed through the sort of the collagen, because it's not knitted together as well. And that's a EDS sort of indicator. If you get them for other reasons, but if you've got someone who's got those, and they tell you I've got digestive issues and I've got pain, and you might start thinking, oh, this could be a potential EDS person. So yeah, I've sent a couple of people off to rheumatology based on that. And yeah, they got an EDS diagnosis that they wouldn't have necessarily got. So yeah, there are a few things you can be on the lookout for physically, I guess.
Mm-hmm. And so is that the pathway for diagnosis? Is it to go to a rheumatologist?
Yeah, I mean, it's not easy, I'll be honest with you. So it's either rheumatology or a geneticist. Now, hypermobile EDS is the only form of EDS that we do not know the genetic cause for. So we know the gene for all the other types of EDS. We still don't know the hypermobile gene. So you can't do a blood test and be diagnosed. So with hypermobile EDS, it's a clinical diagnosis by a geneticist or a rheumatologist. So a geneticist will rule out, obviously, all the other types of EDS and check that there's not a more serious type of EDS like vascular. And then typically rheumatology will diagnose. Now, I don't know what it's like in Australia, but it's very, very difficult to get a diagnosis here in the UK. And I know it's the same in the US.
Mm-hmm.
We have long waiting lists, first of all, on the NHS. But many rheumatologists don't want to diagnose it. And that's another reason we have a long delays in diagnosis, or people are misdiagnosed, often with things like fibromyalgia, because they often present. Obviously, they both have chronic pain presentations. So, yeah, it's another sort of barrier for us, is that it's so hard to get diagnosed. And it's heartbreaking, really, because people wait a long, long time for these appointments and then they're just dismissed. And there's a lot of misconceptions, of course. You might have heard of the Baton score. The test. You can Google it have a look at what's involved in that if you've never heard of that. But that was the first sort of scoring system to diagnose someone with hypermobility, and it's called the Baton score. So it looks at a lot of joints around the wrist and the fingers. Can you bend over and put your hands flat on the floor? It only looks at a few joints. It is not a whole body assessment. So a lot of people, the rheumatologist will do the Baton score and say, oh, you've only scored 2, you're not hypermobile, you don't have EDS. And that's just not true. When you see them moving about and you look at them, you're like, they're clearly hypermobile. But once someone's done that Baton score and they've dismissed you, it's super, super hard. But luckily we have some other assessment tools, now becoming available, rather than just relying on that Baton score. So yeah, it's a tricky journey, to be honest.
And one last question before I'd like you just to touch on your integral movement method. But if we are working with somebody with EDS in studio, are there anything that we really need to be super careful of? Like, are there danger zones that we need to be thinking of, or, do we just work with them, like you've said, slowly within good joint placement, and within their capabilities? So what are some things that we really need to be careful about?
Yeah. So, you do need to modify for people with EDS. So, yeah, for me, going slow is really important. And I think I mentioned, sometimes people can only do 1 or 2 reps of an exercise, and that's fine. Yeah. Some people are so deconditioned because they've been scared to exercise, they've had bad experiences, etc. They're in pain. They've become very deconditioned, and EDS people do decondition quicker than other people. So we lose our tissue tolerance, we lose our muscular tone. So we've got to be that's something I really want to stress, is you've got to be so careful when working, especially when you're, with a new client, because and it's not that we do it on purpose, but sometimes we inadvertently give them too much to do, or we might push them too much, and they will have what we call a flare up of pain, of dysautonomia, of, fatigue. And it's not like they will wake up the next day with a bit of muscle soreness, which we all would get. They can be in bed for like a week or 2 weeks. Yeah. So we really have to make sure the things we're giving them are appropriate, are safe. We really, because of the deconditioning, we have to build their tissue tolerance. And remember all the autonomic stuff and the nervous system. A lot of people work on helping them feel safe, because a lot of people have never felt safe. They've never felt listened to. So go slow, be really mindful. If they don't want to do something, there's a reason. We can't force them to do something they don't want to do. Yeah, be careful with things like weights and loading them too quickly. Again, we're very good at cheating. We can power our way through something, and then the next day we're in absolute agony. I talked about stretching, be careful with the stretching. We don't want to, just because they're mobile doesn't mean we want to be pushing them into these, wonderful shapes and everything. And of course, be mindful of your patients who have things like POTS, the postural orthostatic tachycardia syndrome. They're the ones who can suddenly faint on you, all of a sudden. So you've got to be careful. Don't change their position too often. Don't have them hanging upside down on a Cadillac, common sense things. Don't have them standing for too much. Look for signs like blood pooling in the legs. Is their skin changing color? Are they sweating? Are they, be really mindful. You've got to have big eyes when working with these clients, because there's lots of things going on. Yeah. So yeah, a lot of it's common sense, but in particular, it's more about being respectful of, we don't want to get them to have those flare ups. And a lot of people have good days and bad days. And on the good days, they feel like they can do loads. And we do. We think, great, I feel amazing today. I'm going to really go for it. But that can then cause a big crash the next day. So even on the good days, don't be tempted. I would say EDS tricks you. Don't be tempted to push on the good days. Just enjoy the good day, but don't do more on the good day. Yeah. Keep a nice, even trajectory of progress. It's going to be slow progress. Yeah. We're going to progress slower than non-EDS clients. Yeah. So don't worry about that. And it might be 2 steps forward, 3 steps back. And that's okay too. That is just the nature of the condition. Yes. I think that's all I can think of at the moment. But yeah, hopefully that's helpful.
Yeah, very helpful. And from working with a few people, I do find that consistency is key, so maybe it is just, 15 minutes a day or 10 minutes a day at home, rather than just, a whole hour every week. It's those little snacks of movement, of reconnecting, of taking time out to really calm the nervous system and start to be in your body when you're not used to being in your body.
Yes, totally spot on. Consistency is key. You're absolutely right. Some people can't even do an hour of exercise. I have some clients, we do half an hour because they cannot manage an hour at the moment, which is fine. So, yeah, we do have to tailor things, be a bit flexible with how we work with these clients. But yeah, if, like you said, if they can do 10 minutes a day or maybe every other day, so much better than doing an hour crashing and not doing anything for 2 weeks, which is what happens. And that's the cycle we want to break. Yeah. I'd rather have 10 minutes, small steps, than trying to do a massive step and paying the price for it. So, yeah, consistency is a big factor. So, yes.
Jeannie, could you tell us about your integral movement method? Is that something that is suitable for movement educators, or is it purely for people with EDS and hypermobility?
So, yeah, the IMM is a method that I designed for hypermobility. So it's in my book, Hypermobility Without Tears. And I've actually got a new book that I'm just finishing, hoping to come out next year for practitioners. So Hypermobility Without Tears is really written for patients. It's, an easy read. The new book that's coming out is for practitioners. So it's got a whole section on exercises, but it also a lot of research, the current latest research into the different principles that make up the IMM. So yeah, as I touched on, the first 2 principles are breath and relaxation. They kind of go hand in hand, but this is super key when working with somebody with, as we talked about, with EDS and calming the nervous system and releasing some of that tension from the tissues. Then we move on to proprioception, which we talked about as being a big factor. We know people with hypermobility lack proprioceptive awareness. So this is all generally low key. So a lot of supine stuff, either on the mat or on the reformer or on the trapeze table, a lot of feedback. Yeah. So very gentle breath, relaxation, proprioceptive work. Only then do I move on to stability. So starting to work on maybe a little bit of load, like to start stabilizing the joint. And then we come up to work on balance. So then we start to make it a little bit more challenging. And finally, the final module is posture, because posture kind of emerges from doing all the other things. I don't believe posture is something you can just fix and intellectually tell someone how to stand. It needs to be embodied. It needs to be a sort of a unconscious thing. So that kind of evolves from all the other work. So I generally work in that order with my patients. And yeah, as I said, I do educate all sorts of, so PTs, physios, yoga teachers, Pilates teachers, massage therapists, anyone interested really in the body and working with EDS patients. So I do run training through the EDS Society. So we go into these modules in depth. So yes, that's kind of how the IMM works. And we're just about to publish 2 papers actually on it from my very first online hypermobility course called Strengthen Your Hypermobile Core, which we did, it was a while ago, 2018, we started the research, but we're just about to publish the results of that. We had a massive trial of, had over 600 people enroll on this study to do this specific hypermobility online course. And the stats are really, really positive in favor of using the IMMs. So, it's really a turning point, I think, in exercise information for hypermobility, because, as I said, the research is very lacking in EDS in lots of arenas. But even now, there is still no gold standard evidence-based method for treating hypermobile or EDS patients for exercise or in rehab. So we're hoping this research really, really contributes to that and helps actually establish the first exercise program that is evidence-based for our hypermobile community. It also works because it's so gentle and it is about calming the nervous system. It does work with, I use it with chronic pain patients as well, fibromyalgia. My ME and chronic fatigue patients, they really love it as well. So it works for a lot of those comorbidities because it is gentle by nature. Yeah, it's very gentle. It's very much about embodying the work and creating sensations. It's not about teaching someone hundreds of exercises. Anyone can teach exercise, right? There are thousands of exercises out there. But how are we delivering that information so that it is delivered in a safe and effective way to a hypermobile individual? So yeah, it's exciting times. And hopefully, as I said, by the end of this year, we might have those 2 papers actually published, and that would be super exciting.
Fantastic. I'll definitely keep an eye out for you. Now, Jeannie, I know that I've definitely seen you on YouTube. And in fact, I've sent clients to your YouTube channel, to get some ideas for home program. Is your YouTube, if people go to your website, will they find that on there, and your Instagram and everything as well?
Yes. So there are links so if you go on my website, jeanniedibon.com, there are links at the bottom to my YouTube channel, which is called the Hypermobility channel. So we've got, I think, 270 videos. So there are exercises, but there's also education. And I've done some really nice live classes on there on different parts of the body. So foot, shoulder, hips, knees, necks. So they're really nice. They were done live, so they're very natural. Yeah, really, if you'd like more sort of exercise information or education around particular joints, please go and check those out. But there's loads of content on there. Yes, and I'm on Instagram, I'm on X, Twitter. I can't get used to calling it X, but I'm on X.
No one can.
Weird, isn't it? I'm on Facebook, LinkedIn. Yeah, so you can find me pretty much on all the platforms. It'd be lovely to connect to your listeners as well. And for patients, but I do have a lot of therapists on it as well. We have the Zebra Club, which is my app. And that's really movement, education, and community. So it's an app, mobile app, where again, we have lots of movement content, but also we have expert EDS guests every month who come and talk to us about lots of different aspects of EDS. And we have this massive community. I mean, it's huge, right? So we keep it a very positive environment. And it's amazing how powerful being part of a community can be for people's healing. I remember a lot of these patients have been isolated. No one's ever listened to them. They've never met anyone who's got EDS. A lot of people are, living in rural places, or they're housebound, or, they find it hard to interact socially. And now they have this online community where they can meet other people, make friends. I mean, it's just wonderful to see. So yeah, the Zebra Club, if you have any patients who are interested in, looking for more home support, please do send them to have a look at the Zebra Club, because it's really quite a unique space.
Oh, that's awesome. Yeah, I've had a look at all of your stuff. You're a wealth of information, a wealth of knowledge, and you share so much. Speaking to It's a reminder of the power of Pilates. It's, a reminder of the magic that we can bring into somebody's life just by sharing our experience and our knowledge. Thank you so much for joining me today, Jeannie. I really appreciate you. And all of the information of how to get onto Jeannie will be in the show notes today, of course, and in our newsletter. If you haven't yet signed up to the Pilates Muse, it's a bi-weekly publication, and I'll definitely share some information about Jeannie in the newsletter if you're looking for more.
Oh, thank you.
Thanks, guys, for listening. You'll be seeing me next week on the Pilates Lounge. My name's Katie Crane. I'm the Pilates professional. Take care, everyone, and I'll be speaking to you soon.